things osteoporosis. And I'd like to start by saying thank you very much to Felicity Pyrlis for giving up her time this evening. She's been seeing patients all day, as you just heard from her. Felicity is an endocrinologist looking after lots of chronic conditions and with a real special interest in osteoporosis. So Felicity is going to teach us everything that you need to know about osteoporosis tonight. Felicity's been generous enough to present to our team before at Kieser, and she's a wonderful presenter, and I'm sure there'll be plenty of questions tonight. So when you have got a question, my job is to make sure that all of those questions make their way to Felicity. So there's a Q&A function down the bottom. So I'd love if you could post your question in the Q&A function, and then I'll track it as we go. So if it's on topic at the time, I'll jump in and I'll ask Felicity. And if it's on a slightly different topic, I'll leave it for that time, and I'll try and come back to it later on. Felicity and I have discussed that this is probably going to result in quite a few questions. So we'll make sure that we've got plenty of Q&A time at the end. So Felicity not only is an endocrinologist, but she's also a client of Kieser, and Felicity might share part of that story this evening if she would like to. So there'll be a little bit in here tonight about exercise, but we'll also cover all of the other topics outside of exercise as well. So you walk away from this feeling really confident that you know a little bit more about osteoporosis. So once again, thank you very much, Felicity, for your time. And I'm going to hand over to you now. The floor's all yours.
Thanks, Tim. So let's get going. So Tim and I would be very happy for you guys to send your questions in as if something comes up which is of interest to you. We'll bounce back and forth, and Tim will pop up and pop out, and we can address anything that comes up during the meeting. So this is what we're going to talk about today. So it's important just to have a bit of a definition of osteoporosis and why it's important, some of the underlying causes, and most importantly, why most of you are probably here to talk about how we can help in terms of both non-pharmacological and pharmacological therapies. So most people think of bone as being static, solid, something that just holds the body up. But in fact, bone is a really dynamic and highly cellular tissue, and new bone is constantly being laid down, with old bone constantly being resorbed. And that's what is needed in order to keep the skeleton strong and to stop it from breaking. And osteoporosis is a condition which develops when the balance of the laying down of new bone and the resorption of old bone is disrupted. And you end up with low bone mass and a disruption in the cellular structure of bone, which leads to an increased risk of fracture. So most of you will know how osteoporosis is diagnosed, but it's using DEXA, which is a specialised form of X-ray. Really, most people are a bit scared of the radiation in X-rays, but DEXA is very low radiation, about 1/10 to 1/4 of the radiation you'd get in a flight from Sydney to Melbourne. One of the questions I commonly am asked about diagnosis of osteoporosis is, well, how come I've got it in my hip and my spine but nowhere else? And the answer to that is that the two sites that are standardized for diagnosis of osteoporosis are the spine, the lumbar spine, so the lower end of the spine, and the hip. So they are chosen by the WHO as reflecting the density of the entire skeleton. So it's not that you don't have osteoporosis elsewhere, it's that those are the two sites which are used for diagnosis of osteoporosis. We don't measure every bone in the body, just those two sites. And from this specialised X-ray, the DEXA, we get two scores. One is the T-score, which compares your bone to the bone of a young adult in their 20s when you should attain the peak bone mass. And the Z score compares your bone mass to those people of a similar age to you. We look at the mean and then how far away from the mean you are. So a T-score of minus 2.5 standard deviations from the mean or less than that is osteoporosis. A T-score between -1 and -2.5 is this pre-osteoporotic condition. It's not normal, but it's not quite osteoporosis. And anything from -1 or above is normal. Do you have a question for us, Tim?
Yeah, Felicity, it was very much relating to osteoporosis and osteopenia. Jody asked right off the bat, she said, well, how does this information relate to osteopenia? And I'm sure it's something that you might come back to, but I thought I'd just pass on Jody's question straight away.
So you could really look at it as a continuum. So osteopenia really is an identification of low bone mass, which is likely to progress to osteoporosis. And in fact, osteopenia still puts people at an increased risk of fractures compared with their age-matched controls. So if you have osteopenia and you've had a fragility or low trauma fracture, which we'll go on to in a minute, we still, for all intents and purposes, classify you as having osteoporosis, even without a T-score of less than -2.5. And that, which leads me to why osteoporosis is important. And so we'll continue to talk about this issue now. And so this is the reason why osteoporosis is important. It's because of fractures. So you might see here a fracture through the hip, and here a fracture in the vertebra, where you see this vertebral body is much shorter in height than the two adjacent vertebral bodies. And this is really why osteoporosis is important, because 1 in 3 women over the age of 50 will have a low trauma or minimal trauma fracture due to osteoporosis. And 1 in 5 men over the age of 50 will have a fracture due to osteoporosis. And fractures really cause a great deal of morbidity, so disability in the long term. There's actually a 25% risk of death from hip fracture, and even more people end up in long-term care after hip fracture. So the consequences of a serious fracture can really be devastating. And the problem with osteoporosis is that the vast majority of people who have a fracture related to osteoporosis have really no warning that they have osteoporosis and don't know they have it until they develop a fracture. So by knowing you have osteoporosis, you've actually are one step ahead in preventing significant morbidity. So really, a lot of people worry, is this ache or pain due to osteoporosis? But in fact, it's silent. It's a painless condition until you have a fracture. And the fractures of most concern are those that occur with minimal trauma. So with the sort of degree of trauma you wouldn't ordinarily expect would cause a serious injury, you can develop fractures in osteoporosis with minimal trauma. And the 3 most common types of fractures that can develop with minimal trauma in osteoporosis are those of the spine and hip, and also the wrist. So those 2 that I showed you before, but also the wrist. And it's important to recognise that most people who have a bit of back pain sort of dismiss it as a normal consequence of aging. But in fact, if you have osteoporosis and you have back pain, it's important to get an X-ray so you can exclude a vertebral compression fracture like I showed you earlier at diagnosis, because that has implications for your future risk of fracture and how we would treat you. So the other important reason to know is not just about non-pharmacological management, but also early diagnosis and effective management can really reduce the risk of falls and fractures. And pharmacological therapies, so medications, can really significantly reduce the risk of fractures of the hip by 40%, vertebral fractures by 30 to 70%, and other fractures like wrist fractures, for example, by 15 to 20%. So that's a pretty significant improvement. So when you diagnose, Tim, do you have a question?
I just thought I'd jump in, Felicity, and because I had two questions pop up about DEXA and I didn't quite get the chance to jump in during it. The first one was, is a person's height factored into a DEXA scan? Claire asked that one. And then Ingrid asked a question that I've read somewhere that a DEXA scan only measures bone quantity. However, the authors of the article argued that bone quality is also important, yet this is not measured. So have you got a comment for Ingrid about quantity and quality, and also for Claire about a person's height being factored into DEXA?
Height is measured when you have a DEXA scan, but it's more measured to monitor whether there's been loss of height over time. So I think an important thing which I didn't mention earlier is that if you have a DEXA scan, we use that measurement every 2 years or so to monitor how your bone density is traveling. And we recommend that you use the same machine every time because there are differences in using different machines. So the two different machines aren't directly comparable in terms of their DEXA measurement. Height is used, but it's not directly applicable to the bone density as measured by DEXA. The second point about quality of bone is actually an excellent point. So that is correct. Bone density, or the DEXA, the grams per centimetre squared bone density measurement that you get on DEXA, doesn't tell the whole story. It's absolutely true. And in fact, you know, there is an argument that DEXA can be quite a poor measure of risk. It's the best we have at the moment because there are experimental things like quantitative CT scanning, which looks at the quality of bone, but that hasn't been standardized by larger bodies. So DEXA is what is used in all the medical trials of pharmacological agents to basically look at treatments, etc. So it's the best we have. It's not perfect.
And one more, Felicity, on DEXA, and I think this one is relevant. It's kind of a two-part question. Mandy, who's a physio, said, you know, should older adults be requesting a DEXA scan? And then Suzanne asked, is there government funding for osteoporosis? I think she's implying DEXA scans like there is bowel or breast screening. So who should get a DEXA scan and how do they go about it, I suppose, to summarize those two questions?
So the Medicare rebatable items for DEXA scan are age over 70. If you've previously been diagnosed for osteoporosis, you can have a Medicare rebatable scan every 2 years. And the other ones that you can use to get a Medicare rebatable scan are fractures with minimal trauma, various medical conditions like thyroid conditions, parathyroid conditions, conditions of malabsorption like celiac disease, Cushing's syndrome. If you've had prolonged periods of time without menstruating prior to the age of 45, which is a risk factor as well. I'm going to go through quite a few of these in this section about causes of osteoporosis. So if you have a reason to develop osteoporosis early, you're entitled to an early bone density scan. Otherwise, everyone over the age of 70 can have a bone density scan to check their bone density. And certainly if you have any of these risk factors, you can have a DEXA scan and should actually be screened with a DEXA scan. So women who are postmenopausal, and it's also important to point out that even if you don't qualify for a Medicare rebatable scan, if you have a really strong family history of osteoporosis and you're postmenopausal, it's not unreasonable to pay for your own DEXA scan. They're not super expensive. It's in the region of, more than $100, less than $200, that sort of thing. Of course, depends on where you get it done. But even without Medicare rebating it, it's not unreasonable for you to go and have a DEXA scan if you have strong risk factors. But you would qualify. So in women who under the age of 45 have had prolonged periods of time without menstruating, such as in the condition of anorexia nervosa or low body mass, men with low testosterone. There's also certain medications which can predispose you to osteoporosis, like anti-epileptic drugs, prednisolone, which is a common anti-inflammatory drug if you've had prolonged periods of that through your life. There's also certain drugs which are used in IVF and chemotherapy, thyroid or parathyroid conditions, kidney or liver disease, gut conditions, etc. Rheumatoid arthritis is also a big one which can cause osteoporosis, and things like Cushing's syndrome, which are rarer. So I'd be hopeful that a lot of your doctors, if you have any of these underlying conditions, could flag these as a risk and prompt you to have a bone density scan to evaluate whether you're at risk. So now are there any more questions about that, Tim? Because now might be a good time to go on to some non-pharmacological therapies.
No, there's lots more questions, and I'll try and jump in when you hit the topic.
Okay. Awesome. So I'll go on to the non-pharmacological therapies first, and there were some pre-presentation questions sent through about this stuff, so I'm going to try and address some of them. So of course, probably one of the most important things is if there is a cause underlying which could lead to osteoporosis, it's important to identify and correct that. There have been a number of times, for example, that I have detected people having celiac disease or hyperparathyroidism, which are underlying causes which can be treated and can lead to improvement in bone density without specific medications for osteoporosis, just by correcting the underlying cause. So that's really important. And we'll talk a little bit about, of course, exercise and falls prevention, but also vitamin D and diet, including calcium, protein, other factors. So I might have to get Tim to talk to this a little bit in a minute, but yeah, I think it's, of course, being Kieser, I think we're all interested in exercise. One of the main things that exercise is really important for is falls prevention, and also improving bone strength, improving bone density, and preventing falls. Resistance training is really important to build up strength, and then weight bearing exercise. And I'm going to get Tim to jump in here, because exercise, although I love it and I think it's essential for bone density, it's not my area of expertise, and Tim as a physio has a lot more expertise in this area.
Yeah, Felicity, I just want to touch on these couple of points, because we get, as a physio, I get heaps of questions about exercise, and I'm sure as an endocrinologist, you do as well. And Ray asked a question in here about, can strength training increase bone density, or does strength training just increase muscle mass? And so that's my second point there, is what Felicity's been talking about so far is that there's a natural loss of some bone density over time, but osteoporosis is the excessive loss of bone density. So in some cases, strength training and exercise can increase bone density. And I've certainly seen DEXA scans where osteopenia has been reversed, or osteoporosis has become osteopenia, and we can have that positive result. The benefit of exercise is that it does lots of other things as well. So even if you just minimize your loss, which is still a really positive result, the other positives that you get out of strength training is, because your muscle mass will increase, it will decrease your risk of falls and increase your balance as well. And like Felicity's been talking about, that's one of the major concerning consequences of osteoporosis is, if you do have a fall, then you're much more likely to be at risk of fracture. So the next question that I often get is, well, I walk a lot, and there's quite a few questions here about why I do this type of walking, and I do weight-bearing exercise. And although walking is a weight-bearing exercise, it just doesn't put enough force through the bones to be able to stimulate them to turn over as much as what we would like. Walking's great, and definitely should be part of everybody's, where possible, part of everybody's physical activity regime. But if you've got osteoporosis, I'd highly recommend strength training, because you can do it high resistance, which is what you need for results, but also you can do it at a slow speed and a really low risk. Ideally, we would love you to do some impact exercise. So impact, for example, might be something like jogging or running, but it could also be something like dancing, which is moving a little bit quicker. First thing is, jogging and running is not going to be appropriate for everybody. And secondly, even if impact exercise is appropriate for you, it's only appropriate after you've got a really strong base of good strength beforehand. So if I had a patient who turned up to me, 65-year-old female who's just been diagnosed with osteoporosis, and she said, I want to go for a run. Well, that's a really high risk exercise. And it's probably why in some cases exercise gets a bad name, because people go from here to here straight away. What I would advise in that case is, I really want you to start exercise. And if eventually you'd like to get to some activity like that, then that might be okay. But we've got to step through a couple of tick boxes before that. And the first one really is strength training, because of the safety element and because of all of the other protective parts to it as well. Felicity, I don't know if there's any other really common questions that you get regarding exercise.
So I think the commonest comment I get from people is, well, I do a lot of walking, so that's fine. So I actually really relate to that, Tim, because walking is amazing for your cardiovascular health, really great overall, but for building bone strength and for stimulating bone formation, it's not the best exercise. Really important for your cardiovascular health. It's good for balance, but yes, it needs to be varied. And I think the approach that I like about Kieser is the starting low and going slow and gradually building up and increasing gradually over time. So we're talking about a really long-term approach, which helps stimulate the formation of new bone, but also reducing the risk of falling. So really, if you never fall over, your risk of fracture is very significantly reduced, probably more than we could do with any medication if you just don't fall over.
Yeah, it's amazing to think that. There's plenty of questions there about exercise. I think one that's a really important one to touch on, Leonie asked about, well, my daughter, what can I do for my daughter and building up her bone density? And it is really important, the bone density that you build up in your prepubescent years, because that is a time when your bone is really sensitive. So the more impact activities that your kids can do, and impact's really safe when you're much safer when you're a kid. We strongly encourage that as physios. So physical activity in young kids is really, really important. We had another question about wearing a weighted vest whilst walking. I like that innovative idea. And yeah, that's a great example of strength training because you're adding more resistance. I don't think it would be sufficient, and the limitation of that is that it's not as specific. It's a bit general to everywhere, but it would be a way to increase the load of walking and increasing how much osteogenic benefit it does have. And then the final question was about, well, what does Kieser do for balance? And firstly, the evidence is that strength training is fantastic for balance, and strength training alone can help improve your balance. But we realized that there was a group of people that needed a little bit more work for balance. So I'm a physiotherapist, but the exercise physiologists at Kieser now take osteoporosis classes for people who've either been diagnosed with osteoporosis or are at high risk. And that will include some strength training exercises and some balance exercises. So if you're a member of Kieser, ask your exercise physiologist. And if you're not a member of Kieser, just give us a call if that's something that is of interest to you, because both of those things together work really well. Felicity, I'm very conscious of time, and it's 7:30, and I know you've got a lot of other content to be able to go through. I'll get back to having a look at the questions and chiming in. I'm sure there'll be a few more about exercise that we'll need to discuss later on.
Excellent. Okay, so other things we can do which are not prescription medications, and many of you, I'm sure, are on vitamin D already, because we know that over 30% of adults are vitamin D deficient. That's particularly true where I am in Melbourne. So generally the guidelines are to aim for sufficiency of vitamin D. What is sufficiency is sometimes debated. I tend to aim for the higher end. So I think vitamin D is very safe. It's difficult to get too much vitamin D, but I think that I think aiming for a level of vitamin D of 90 is just sensible, because we know that vitamin D is really important for bone strength. And there's also a few drug therapies which can cause problems if you give them to people in the setting of vitamin D deficiency, because if you're vitamin D deficient, when you receive these medications, it can pull the calcium out of bones, because you need vitamin D in order to absorb calcium properly. There has been some studies looking at intermittent, very high dose vitamin D, and there's not great evidence that it's beneficial to do it that way. It's fine to take weekly doses of vitamin D, but the very high dose intermittent monthly doses may even increase the risk of falls slightly. So I tend to aim for more regular vitamin D replacement, and aiming for really robust levels of about 90 nanomoles per litre. Calcium is a big one that's been hotly debated over recent years. And in fact, not long ago, there was a big article in the Medical Journal of Australia looking at calcium supplementation in osteoporosis, and which actually found that there's really not much demonstrated benefit from calcium supplements. And in fact, they're more likely to cause issues, commonly constipation, bloating, kidney stones, but there is also a small suggestion that they can slightly increase the risk of heart disease if taken in excess. So I think that risk is actually overinflated a little bit, to be honest. My reading of that data is that if you have sufficient dietary intake of calcium and then take excessive supplements, that can be a cardiovascular risk. In general, I think the upshot for calcium is that you're better off getting it from your diet. So 3 to 5 serves of calcium-rich food a day is generally reasonable, because in postmenopausal women and men over 70, we usually recommend 1,300 milligrams per day, because with age, calcium is absorbed less effectively from the gut and can be lost more through the kidneys. And a good rule of thumb for calcium intake is a serve of dairy times 300 milligrams is about what you'd need. So that would give you about 1,200 milligrams a day for 4 serves of dairy. So that is in the region of reasonable. There are certain conditions where calcium replacement is necessary, and those things can be certain medications, if you've got renal disease, kidney disease. But usually calcium supplements won't exceed 600 milligrams per day. So the upshot for calcium is you're better off getting it through your diet. Depending on medical advice, you can get it through supplements. And if you have inadequate dietary intake of calcium, then a supplement is not a bad idea. That can be taken intermittently, doesn't have to be taken every day. This is just a website that addresses the calcium intake of various foods. There was a question beforehand, before the presentation tonight, about people on a vegan diet with seafood, and you can see actually in here there is a number of options like tofu and sardines, for example, have quite a bit of protein, but I just direct you towards this website from Healthy Bones Australia that has calcium intake in common foods. So I think dietary sources of calcium are best. It's really important in general to have adequate intake of nutrients and protein. Being too thin is actually a risk factor for fractures and a risk factor for osteoporosis. So we would normally aim for a body mass index within the normal range. There is good evidence that if you have a body mass index below 19, your fracture risk is elevated in osteoporosis. And certainly we know that relative energy deficiency is a risk factor for preventing you from getting to your peak bone mass and causing osteoporosis. Sadly, everything has to be done in moderation, and we know that too much caffeine can increase calcium loss. So we usually recommend moderate caffeine intake, and if you're going to have a coffee, have it with some milk in it. It does caffeine does impair calcium absorption, but at least if you have some milk with your coffee, you're having some calcium.
Felicity,
yeah.
Oh, sorry about the feedback. It just takes a second to adjust. Do you have a guideline on what caffeine in moderation looks like? Are we talking 2 cups of coffee a day, 3 cups of coffee a day?
There's no magic number, but I would say 2 to 3 cups is moderation.
Yeah. Okay.
Yes.
And while we're talking about vitamin D, this kind of might come in the next session about pharmacological. Is vitamin D alone sufficient? What role does vitamin K play?
Yeah. So vitamin K, there's no good proper scientific evidence for at this stage.
Okay, but it's certainly something that's capturing a bit of attention? Is it being studied widely? Is it?
The answer is, at this stage, there's no great scientific evidence for vitamin K, but it doesn't reach the level that we would recommend vitamin K usage at this stage. And in terms of whether the non-pharmacological therapies are sufficient is really sufficient, without the medications, really depends on the individual. So I think and that's actually what I'll talk a little bit about that in the next section as well, because I think that you really need to take a very individualized approach about what the cause is, what remediable factors exist that we can address without medication. And also, if you take a longitudinal approach and look at what the bone density has been over a number of years and whether it's stable, declining, or improving, that goes a long way to our decision about giving pharmacological therapy. So the thing you might notice about your treatment with osteoporosis is that we're talking about years of monitoring. This is a long-term condition where things don't change overnight. You don't expect necessarily to, in 6 months have a dramatic change, because bones take a very long time to change. And also some of the interventions we might take at age 60 are really aiming to prevent someone from having a fracture at age 75 or 80 when they're a bit higher risk. So I think that's also an important thing. So you have to take a long-term view when you're looking at osteoporosis rather than an immediate thing. And that can be frustrating, I think, when you're the person with the condition, because you want to see quick results quickly. But it's important to be patient.
Yeah, I think that's an important one to touch on, because it must be so frustrating and a hard change of mindset for people when they do get diagnosed with osteoporosis. And I know, it's a confronting conversation for me to have. You must have it 100 more, thousands more times than I do. Felicity, when I say to someone, you've been diagnosed with osteoporosis, you need to do strength training twice a week for the rest of your life. That's not what people are expecting when they come into my office or yours.
Yeah, that's really, really, really important, actually. And I think that, life's a really long thing, hopefully. And what we're hoping for is that we get to a ripe old age without pain, without fracture, being as healthy as we can be. There's a difference between being 90 and vital and active and being 90 and in pain with fractures. And I think really you have to take a very long-term approach, and regular training is really part of that, and also addressing all these boring non-pharmacological things like weight and nutrition and calcium and vitamin D. It's all part of it as well.
Yeah, there's plenty of questions around this, and I use a stat that one of the best predictors of your independence as you age, so your ability to do the basic things that you want to be doing by yourself, is actually your strength. So your physical activity and how much you're able to maintain that. So it's a tick for, I need to do strength training for the rest of my life. Felicity, I know we're going to talk about pharmacology in a minute, and when we do get to that, there's certainly a few questions from people saying, well, I've been on Prolia for a while. Do I need to continue it? And I'd at this point probably just take a second to say that we can't give individual advice because we have got a couple of hundred people on this webinar, and without knowing all of your circumstances, it would be very unfair to ask Felicity to give individual advice. But I'm sure that's something that you can talk about when we do come to Prolia in a couple of minutes.
Yeah, I definitely can. Yeah. So without further ado, let's get on to drugs. So I think it's important to identify who to treat with medications. So that's the first thing. So that advice we've discussed with exercise, calcium, vitamin D, diet, all of that, falls prevention, all of that is applicable to absolutely everyone. So really there's no one that doesn't benefit from that advice. But in terms of pharmacological therapies, that's a little bit more specific. So I think what we're aiming to do is treat people who are at the highest risk of fracture. So those people, really, I think there's a few categories. So if your age is more than 70 and you have a T-score in the osteoporotic range, the general advice is you should receive treatment. Regardless of your T-score, if you have had a fracture with minimal trauma, so wrist, hip, spine, with minimal trauma, even if your T-score is minus 1.2 in the mildly osteopenic range, you have functionally have osteoporosis and should receive therapy. There's also other circumstances where we may choose to intervene with medication. So if we know someone has a slightly low bone density in the osteopenic range and we've been monitoring them and they're losing bone actively despite doing all the non-pharmacological therapies, then that we may intervene in that situation as well with drug treatment. In Australia, who we identify for subsidised pharmaceutical agents really depends on the pharmaceutical benefits scheme, which is the government scheme under which medication is supplied. So in order to qualify for medication, you have to meet specific criteria. So one is the first thing I mentioned, which is people aged 70 or older with a bone density scan of T-score of minus 2.5 or less. Or those, the other condition is those patients who have had a fracture due to minimal trauma. And in fact, the T-score or the bone densitometry, the DEXA scan isn't required for that. So those are two situations in which people absolutely require or absolutely eligible for medication. And I think that's important for you to recognise. Another one of the ways we identify people who may not fit into one of those two criteria is by using these things called fracture risk calculator. And there are two of them that we use in Australia. One is developed in Sydney. It's called the Garvan fracture risk calculator, and I've put the websites up here. The other one is called Frax. That tool was developed in the UK, but is can be modified to Australian. You just put Australia as your region, and it is modified for our population. So the two most important variables that go into any fracture risk calculator are age and prior fracture, and also bone densitometry. The T-score is put in there as well. So our general rule of thumb for who we treat is anyone who's had a fracture risk calculator measurement giving a 5% or greater 5-year risk of hip fracture, or 10% or greater 10-year risk of hip fracture, or a 15% 5-year risk of any fracture, or greater than 20% 10-year risk of any fracture. I won't go into these in much detail, but just to mention that this is part of our tool for identifying those people at high risk of fracture. And really that's why osteoporosis is important, because we're looking at preventing fractures. This is the Frax tool, which has been modified for Australia, and this is the Garvan tool. So anyone can access them online and input their data. So here are the therapies that we have in Australia for osteoporosis. So the two most commonly used therapies, which you may have heard about, are the anti-resorptive agents, which are bisphosphonates, or Prolia, denosumab. So the bisphosphonate medications are either oral tablets, so you have alendronate or Fosamax, or risedronate or Actonel, and they're taken as monthly or weekly tablets, or there's zoledronic acid, which is an IV infusion that you have annually. And those medications are time limited for between 5 to 10 years of therapy. They aren't normally indefinitely continued. Prolia is one of the more commonly used medications now, and that is a 6-monthly subcutaneous injection. And we will talk about cessation of that because I think that's an important one. I'm not going to talk much about raloxifene, which is a selective estrogen receptor modulator, because it's not used very frequently actually these days. And it doesn't have, it's got good data for preventing vertebral fractures in the back, but not good fracture data for any other sites. And there's 2 other medications which are used in the setting of severe osteoporosis. So in order to qualify for either of these 2 agents, you really require, there are quite strict guidelines in who we're allowed to use them in, and they are people with more severe disease. Hi, Tim.
Felicity, we've got a heap of questions here, but I just wanted to, I'll let you get through your next slides, but I did want to share one of them. I actually thought it was a really good question from Belinda, who simply said, can I have drugs earlier to build my bone density and prevent becoming osteoporotic?
That's a really difficult question to answer, actually. So no, the answer is generally no, we don't give people drugs to prevent osteoporosis. So I think that if your bone density is in the osteopenic range and you've never had a fracture, we normally wouldn't give you medication because it really, it's not to build up the bone to make, to increase the bone density. There's more than, you know, as I alluded to earlier, and one of the questions alluded to also, bone density is not the full story. So that's a quantitative measurement, but it doesn't give you a whole heap of information about the bone quality. So that's the first thing. So the non-pharmacological measures you can take with exercise, vitamin D, calcium, are very likely to help improve qualitative measures of bone. You know, I think it's really important to target, especially with some of these time-limited medications, it's really important to target therapy where it's most needed to prevent fractures, because although we have quite a bit of long-term data on Prolia, I tend not to start it in people who are really young unless there's a really compelling indication, because we are talking with Prolia. I'm going to get onto this in a minute, but I tend not to recommend people stop that medication. Bisphosphonates we usually give for 5 to 10 years, but we're looking at the rest of your life, and generally we don't consider osteoporosis to be a curable illness. So we don't consider that you're treated for osteoporosis, then cured, and then you never manage it again. This is, once you have osteoporosis, it's something that requires really lifelong management. And I think that's really an important concept to grasp in this. So let's just go on to bisphosphonates, which are possibly the most commonly used medications. So they're the ones that you can have as either tablets, so oral Fosamax or Actonel, so alendronate or risedronate, or a yearly infusion of aclaster. And so we limit those medications to between 5 and 10 years of therapy for reasons of side effects which can occur. And these medications are basically concentrated in bone under the cells which called osteoclasts, which cause bone resorption. And so they inhibit the activity of the cells called osteoclasts, which resorb bone. And thus the net effect is that of reducing bone resorption and increasing the bone density for that reason. So you shift the balance from too much resorption of bone to inhibit the resorption and increase the bone density. So the most commonly experienced side effects from the oral medications is that of indigestion. So for that reason, when we get people to take it on an empty stomach, stay upright for half an hour afterwards. But it does, these medications do have really good demonstrated anti-fracture efficacy, and they reduce fractures by significant amounts, both vertebral and non-vertebral fractures. There's a yearly infusion which is really convenient because it's once a year. You can get it in the community at, for example, pathology collection centres, things like that. You usually get a bit of a fluey illness after the first infusion, but it does really effectively suppress the osteoclast activity and reduce bone resorption for a year or more, and has really good proven efficacy to reduce fractures and improve bone density. Prolia works in a pretty different way, but it still results in a reduction in bone resorption. So it doesn't stimulate the formation of bone, but it does stop that resorption of bone. And it does that by binding this thing called rank ligand, which is involved in the formation of osteoclasts. So it stops the formation of those cells called osteoclasts, which resorb bone. So basically for the 6-month period that the Prolia is active, it basically stops bone being resorbed, and the net effect is an increase in the bone density. So it's just shifting that balance again between bone formation and bone resorption. So you get a good 6-month stoppage of the bone resorption, and at the end of that 6 months you get a recovery in bone resorption. Now the problem is with Prolia that we are asked a lot about cessation of Prolia. Prolia is really effective. It has really good reduction in vertebral and non-vertebral fracture incidence, but if you stop Prolia, it's a bit of a concern and it needs to be really medically managed closely. So basically, there have been a number of cases of spontaneous fracture of the vertebra in people who've just decided not to go back and get their next Prolia injection. And that happens a few months usually after the Prolia is due. And the reason for that is that you've had absolute inhibition of the cells which resorb bone. Now, if that inhibition if you don't do it with another injection straight away, the cells bounce up above the baseline and they do resorption of bone and drop your bone density. So you actually, with stopping Prolia, your bone density returns to its baseline or lower pretty quickly after that next injection is due. So basically you lose that protective effect that you've had if you stop the Prolia. And that's the reason why at the moment we don't recommend that people stop Prolia. If you have a really compelling reason to stop the Prolia, it's really, really important that you replace it with something like a bisphosphonate medication, like I discussed earlier, which will mitigate that increase in osteoclast activity and reduce the risk that of spontaneous fracture. So it must be replaced with another medication for about a 6-month period if you're going to stop it. I think that's really important to recognise. So I appreciate that people would like to come off medications, but it's important that that's discussed with your doctor and really closely monitored and managed if you're going to do that. Having said that, we actually have really good data for Prolia going into the long term, up to at least 8 years of persistent, ongoing anti-fracture benefits. So I don't expect you to look at the exact numbers, but just to recognise that in people who receive Prolia, there's a really significant improvement in bone density from baseline, and that extends out to 8 years. Similarly, I don't expect you to look at the exact numbers of this. This is looking at side effects and safety of long-term treatment with Prolia. And I think the thing which is important to look at is just the rate of side effects with placebo versus the rate of side effects with long-term Prolia. And you can see actually that the side effects with placebo are actually higher in most of these categories. So actually Prolia is really well tolerated. So if you have a higher rate with placebo, it means that it's very unlikely to be the side effect is very unlikely to be due to the active drug. So just to reassure you, the medication it's really well tolerated and pretty safe in for at least out to 8 to 10 years. The reason I want to touch on the complications, some of the potential complications of therapy, because I know this is what people get concerned about, and I think it's important to reassure you that these are the two big ones that people are worried about with drugs for osteoporosis. One is called osteonecrosis of the jaw, and one is called atypical femoral fractures. So this is osteonecrosis of the jaw, which is a condition where if you have invasive dental work, for example, the area of bone under the extraction site doesn't heal properly. This is atypical femoral fracture, where you can develop atraumatic. So with no trauma, you can actually just get a fracture of the long bones in the leg. Now, they're generally thought to be complications of long-term bone suppression, so which theoretically can occur with long-term treatment with bisphosphonates. Really, that's the reason why we limit bisphosphonate treatment to between 5 and 10 years. So with both of these examples, the risk is very, very low. We evaluate everyone that goes on medication for risk factors for these things. So the risk factors for the jaw complication are really in people who are smokers with poor oral hygiene, who have chronic issues with dentition, don't see dentists regularly. And the risk is really very, very, very low in people who have regular dental checks. People who are on a single oral agent of bisphosphonates for 5 years, the risk is exceptionally low. Again, the risk of atypical femoral fracture is extremely low in people on short-term bisphosphonates, and also extremely low in people on Prolia. And it's important to recognise that there's been no direct causal link established, just an association. So I just would like to, I know that people talk about this a lot, and especially online, but it's important to recognise that compared with the risk of fracture in people who qualify for medications, the risk of complications occurring is actually very low. I'm not even sure if it's worthwhile discussing the newer agents, which are anabolic agents which cause bone formation, because they're really in a very select group of patients and should be discussed with your doctor. But do we have any more questions, Tim? Oh, sorry, you've got your mic on mute.
We do have a few more questions, Felicity, but I was just going to say that we haven't got any on these type of medications. Most of our medication questions were in relation to Prolia, for sure.
Okay, excellent. So I'd be happy to take some more questions at this time, I think, because I'm not sure we have time to talk about the more highly specialized medications. They're not of that much relevance to our audience tonight anyway.
Well, Felicity, we might continue with questions for another couple of minutes, but just on the off chance that there's a few people who do need to duck off because it's 8 o'clock, whilst everyone's still here, I just wanted to say thank you so much for your time. It's really obvious to me, Felicity, how passionate you are about osteoporosis and how passionate you are about trying to help people who've had that diagnosis. And I'm sure to the other, and I can tell you now, about 300 people who are listening tonight, that passion really comes through. And for you to have started work at 8 a.m. this morning and seen clients the whole way through and still be giving your time to people to try and help them and try and debunk some of the myths and give people better long-term results, it's really appreciated by us at Kieser and all the Kieser clients that you're able to help, but also appreciated by all the people here tonight. So just a big thank you before I get to the next couple of questions.
Thanks, Tim. I appreciate it. Thank you.
So one of the really big ones, Felicity, was, is osteoporosis reversible? And I know that you touched on this in different points, but I just wanted to ask you that question in a really pointed way so that we could clarify that for everyone.
I have seen people normalize their bone density with medication, with a combination of medication and non-pharmacological management. But generally, I would say it is not a curable condition, and it's more an issue of long-term management.
Yeah, and I think that's I think you said partway through that osteoporosis we don't consider a curable condition. So even if we're able to reverse it, those things that you've done, like the lifestyle behaviors, they're things that need to be maintained for the rest of your life.
Absolutely.
There was one, and I think this is a really important one. I understand that with age, there's an increasing risk of osteoporosis, but people who've been diagnosed with an early onset of osteoporosis, my first piece of advice obviously would be for them to come and see you at Melbourne Endocrinology or another endocrinologist. But any specific advice or any information for us on how many young people have this condition?
So I think the concept of, you touched on it earlier when you were talking about children exercising. I think the concept of peak bone mass is a really important one, because really the bone mass that you end up with after menopause for women or in older age for men really depends on that bone mass that you attained when you're in your 20s and that to that peak. So if you have had issues of childhood illness, certain childhood medications, that will really affect what peak bone mass you're able to attain in your 20s. And I think if there have been certain, for example, illnesses, that's really an important place to intervene. So before you get to menopause, if you have an early diagnosis of osteopenia or osteoporosis, you still have a really great opportunity to have a few more years of normal estrogen levels to help build bone during that time, because you still have the anabolic effect of estrogen, which helps you to build more bone. So I think, that's an important point. And I think you can intervene early with more conservative measures. We tend to leave the medications for later on in your life.
Yeah. Felicity, a question that came up a couple of times was, and this might be a difficult one for you to explain simply, but if a lot of the medications for osteoporosis are 6 monthly or annually, and they have rapid drop-offs at the end, what about if is there a reason that you can't take a little bit of that medication every day for the rest of your life?
Yes, there is a reason. So Prolia, I think you can't compare Prolia and bisphosphonates. So they work in totally different ways. So one's a monoclonal antibody, the other is incorporated into the bone. So the bisphosphonate, the reason you can't take that every day for the rest of your life is because that it gets incorporated into the bone and has residual lingering effects for years after you've stopped taking it, actually. And that's the reason why you don't need to take it for the rest of your life. And if you take it every day for the rest of your life, you can get too much inhibition of bone resorption, and that can make the bone static. So you might recall I initially said that sort of bone formation, bone resorption, little dance that's done in bone over time is really important for bone remodeling and keeping the bone strong. And if you inhibit that too much, then that can lead to problems.
Okay, that makes sense. And I think we'll answer a few questions. I'm very conscious of your time, Felicity, so I'm going to ask one more question. Just before I do, I'm going to give a big shout out to a lady named Beryl Logie, who's done much work for osteoporosis support in Melbourne and formerly headed up the Melbourne Osteoporosis Support Group. So Beryl, it's really nice to see you on this webinar tonight. Thank you for everything that you've done. I just want to end with hopefully what is a little bit of a simple question, or maybe a summation question is a better description, Felicity. So someone walks into your office tomorrow and they've been diagnosed with osteoporosis prior to coming in. What are the most common things that you're talking to people about that are non-pharmacological? Because we understand that there's a bit of pharmacology that plays a role here, but what are the biggest couple of things that you need to have a chat to people where they need to make changes in their life with a lifelong condition like this?
Well, strangely, one of the first things I do is look at what shoes people are wearing, because stilettos are really common and bad for people with osteoporosis. And you'd be surprised how many people still wear them. So I talk to people a lot about falls prevention, footwear, modifying their house, looking around at what's capable of being tripped over in the home. I think that's really important. I always talk about if you don't fall over, you're much less likely to fracture. And, integral to that is exercise. So I always have a conversation about exercise. I always talk about dietary calcium intake. Always talk about maintaining a normal body mass index and making sure you're not too thin. And always talk about adequate vitamin D. So I think they're really good places to start.
Yeah, I think they're fantastic places to start. And the nice thing about all of those ones is they have, otherwise positive health effects as well. Exercise is a really good thing. Reducing your falls risk across the board, regardless of osteoporosis, is a really good idea. So